Christos Boskos, a radiation oncologist that is working both in Athens and in Thessaloniki. And he has his own company, medical company called Stereotactic Radiosurgery.
Okay. Please use the mouse or the arrows, okay?
No.
Yeah. Go.
Good morning. Sorry. I would like to thank the organizing committee for inviting me here. It was really a very interesting invitation for me. I could not refuse that to speak about charged particles from my past, to remember that, and speak about radiosurgery for skull-base meningioma. I have no conflict of interest to disclose. So yeah, it's perfect. Yeah, it's great. Yeah. As I've told you, on the past, I was involved with proton therapy just for a couple of years. Initially, I was a fellow in the Centre de Proton Therapy d'Orsay in Paris in 2003 for 3 months. And that was my first contact with charged particles. It was very interesting for me because I was learned the conventional radiotherapy was a revolution for me. So I continued when I finished with my residency on 2006 to 2008 to train and practice and have research in the same center. We have a signal cyclotron that time, 200 MEV, and we're doing skull-base with conventional proton therapy, and also oval melanoma, and some cases with pediatric. So that was the Center of Proton Therapy d'Orsay. Today is belonging to Institute Curie and have a new facility. I continue in the area of stereotactic radiosurgery and radiotherapy, and this is my experience with radiosurgery, stereotactic radiosurgery. And I'm dedicated on that. I have a training and a practice and a research with different kind of facilities. And the most important for me was my experience in PTS in Paris and my fellowship in UCLA in Los Angeles. This is my certification, international certification in stereotactic radiosurgery and proton therapy from the University Pierre and Marie Curie of 2010. And this is a part of my research on proton therapy for skull-base atypical and malignant meningioma. We published that in 2009 in Red Journal. And actually what we found is that we have to increase the doses we gave in that time, more than 65 centigrades to have a better local control. We published with my friends Luc Felferet and Georges Noël. So I remember from that time that we say our motto was focal is better, talking about radiosurgery and proton therapy, but we always dreaming of carbon ions and the possible advantages, the biology advantaging, so we can have a far better therapy. So let's back to my subject, which is charges for skull-base meningioma. We have charges for the skull-base meningiomas because they are the most common benign CNS tumors. We have increasing incidence as the population is growing older, and we have year by year higher imaging quality. And so we can define residual and relapse disease. And there are a lot of factors affecting our decision for the treatment. And this is age, volume, location of the meningiomas, and of course, the quality of the resection. And they are always in our mind that they have a lot of surgical complications. We're trying to go for resection on this area. So some pairs, general pairs for skull-base meningioma, they're usually in female, more usual in white race. They're usually benign, and sometimes they are atypical or malignant, grade 2 or grade 3. But skull-base meningiomas, they have a better local control. We know that if we compare them to convexity meningiomas. And the reason probably, according to the literature, is they have a low probability of high-grade histology, they have a slower growth, and they have a favor molecular profile. We have a lower KS67 index. They originate in different locations. I described them, a lot of them, but usually we divide them for the Skullbase meningiomas of frontal fossa, medial fossa, and posterior fossa. And actually, the most common is the one in cavernous sinus, cerebropodal ankle, and petroclival. And the most common is the cavernous sinus by far. The treatment with radiation could be the main therapy, single treatment, postoperative residual or relapse disease, and we usually do that with VMAT, radiosurgery, or particle radiotherapy. So my presentation is about radiosurgery, and according to the guidelines of ICRS, the International Stereotactic Radiosurgery Society, which agree with the guidelines of EANS, the Neurosurgery Society European, radiosurgery is very good first-line treatment for small tumors, small meningiomas, asymptomatic for elderly people, and they have excellent tumor control with low rates of complications, and they can be combined with endoscopy and the nasal approach for bony skull-based decompression or limited tumor removal in case we have an exophytic tumor. During about radiosurgery of skull-based meningioma, I would like to remind you the definition of radiosurgery. We working with a high dose in one fraction, with a high accuracy less than 1 millimeter, and we have a high gradient of dose, which means that we have a dose for love outside the target. And this is the advantages of radiosurgery on the area for radiobiology. So we create with radiosurgery more double-strand breaks in DNA of the tumor of meningioma. So this is finally affect in the less DNA damage repair. We have also the antivascular effect and the in situ vaccine effect and abscopal effect, which is coming because of immune stimulation and immuno-upregulation phenomenon. Factors for radiosurgery treatment decision is the size, the location, the rate of growth, the age of the patients, the performance status of the patients, and of course the patient choice. This is an example. Oh, this is my telephone. Someone to close it. Sorry. This is an example. We typically control the organ at risk, its brainstem, optic nerve, optic chiasm, hypophysis. Of course, then we proceed on the contouring of the tumor. And the prescription dose we use include the dose effect on the local control, strongly connected. And also they have the dose conformality and dose follow-up affect toxicity. They are so connected. We use this single fraction with 12 grays. I usually use the 12 grays. And the reason is that with 11 grays, we have a possible working. We're not sure yet. And when we increase the old standards of 14 grays in a single fraction, it's working, but there's no reason because we have a lot of toxicity. So this is a treatment planning, a typical treatment planning with robotic radiosurgery for a cavernous sinus case. Case we have before 1 or 2 years, I don't remember. So something about the outcomes of radiosurgery in the skull-based meningiomas. We know a lot of years before 2003, a paper published, and they say that we have equal, with radiosurgery, we have equal results, long-term results for 3 and 7 years for progression-free survival, comparing with the symptom grade 1 resection. We have a lot of results by the ICRS guidelines, and we have 20 years progression-free survival up to 87%, 10 years local control up to 93%. It's high, really high. And this is more in 20 years, local control more than 80 years, sometimes coming till 90 years. About the clinical follow-up after radiosurgery in skull-based meningioma, neurological improvement, up to 44-45%, and complete symptoms respond up to 23%. But the highest rates you can see that is on cavernous sinus meningioma, which is a very favorable location. And about the improvement rates specific to the cranial nerve deficits after radiosurgery, you can see that we have improvement till the 5 years up to 39%. What about fractionated radiosurgery? A lot of people asking for that. the latest and discussing about that the latest 10 years. We usually use that for large tumor volume as an alternative to the single fraction, and in order to decrease the toxicity, and also in cases that we have a proximity to optic pathway. I described that. So what about local control and toxicity when we use fractionated? I will speak about the two. I refer to the two papers, very important papers from Fariselli, from Italy, both of them. Fariselli published on 2023. He's the ex-president of ISRS, and they have Skullbase, fractionated radiosurgery, Meningiom, 5-year tumor control up to 97% with accepted toxicity, and Conti from Bologna after 2022 published with the same therapy, the same pattern, 5 fractions, 25 grays, prescribed dose, 5-year tumor control up to 19%, and very high progression-free survival, 2, 5, and 10 years. Is there any real radiobiological advance in fractionation radiosurgery? That's a good question. Analyzing the alpha-beta ratio from Meningiom, a group on 2010 published this paper, and they found out that the brain-normal tissue alpha-beta ratio was 2.5, and Meningiom alpha-beta was 3.3 till 3.7. So the authors concluded that there's an advantage, but there's not so much as we think, like the cancer cases. About tumor shrinkage, if we compare fractionated radiosurgery with single fraction radiosurgery, we find out, according to this paper published in 2005, that in single fraction radiosurgery, we have a high rate tumor of shrinkage. So, high-grade skull-based meningiomas. We don't have only benign as I described before. We have the high grades, and this is the grade 2 and the grade 3, and this is the pathology characteristics. There are 2 trials referring on if we have to irradiate for grade 2 meningiomas, skull-based meningiomas, right after gross tumor resection, or we should wait. Both of them, they conclude that we have excellent results in favor of post-operative radiotherapy. So using modern techniques, they say the authors, we can deliver higher doses in the target, and we can have very low rate of high-grade late toxicity, this is a paradox for radiotherapy. And this is the characteristics, this is the paradox existing because of the characteristics of SRS and all these focus radiotherapies. We can give high conformity in the target, that's the reason, and increase dose gradient outside the target. We have a quick rapid fall of the dose. Another paper published in 2020 saying that adjuvant SRS improved post-surgical long-term outcomes in both atypical meningiomas and malignant meningiomas with 5-year survival rising up of 77% and 44% respectively. About choosing the patients, select the patients of grade 2 meningiomas who should choose to do radiosurgery. Actually, is a good choice for patients less than 50 years old. They have previous 1 resection, no previous radiotherapy, and a small volume. It was published in 2021. And what about the factors affecting radiosurgery outcomes? There are a lot of factors described in the literature. The high marginal dose, the small, medium-sized tumors, grade 1, upfront radiosurgery, early radiosurgery, the female sex, younger age, and less conformal plans. In a multivariate analysis of factors associated with improved local control after radiosurgery, Santa Cruz and his colleague published in 2011, they found that center of experience, the experience of the sender is very important. And this is something we have always to have in mind. And finally, there's a lot of presentation in the last 5-6 years about the use of DOTA-TOC PET on the contouring of radiosurgery of skull-based meningiomas. There was a paper published in 2019, and they found out, the authors, that it was easier to define the target for the physician. The planning volumes, they showed to be significantly smaller, and all the physicians, they preferred to conjure with the combination of PET and MRI. And this is the reason you can see that on the left side up, CT scan, the view of the cavernous sinus meningioma, skull-based meningioma. On the bottom, there's the MRI. I mean, the images are not so clear, but when you put the Datatalk, you can see the difference. About complications of radiosurgery for skull-based meningioma, that's the main complications: neuropathy, optic pathway toxicity, facial nerve toxicity, radiation necrosis for brain, normal brain, edema, pituitary gland hormone deficit, headache. According to the SRS guidelines, the neurological duration and the new neurological deficits are very low, and 80% till 100% they preserve neurological functions. Complications are rare, neurological duration for cavernous sinus up to 11%, and permanent morbidity rates for cavernous sinus up to 6%. Yeah, I'm finished. About edema, the skull-based meningioma, low risk of post-SRS edema, and dose and volume is related, but not directly related. So it's a multivariate mechanism with unclear relationship. And this is the last I would like to refer, which is very important. It's a paper published on Lancet by Dr. Control, who shows the superiority of radiosurgery compared to conventional or conformal radiotherapy in the risk of radiation-associated intracranial malignancy after stereotactic radiosurgery. The statistics says that people that they are under radiosurgery, they have exactly the same risk to, like the general population, to have a primary new CNS tumor. So about our group, so radiosurgery, finishing my presentation, we are a dedicated association of people working with radiosurgery, training, certified, practice only with radiosurgery. We established the Greek National Radiosurgery Guidelines in 2019. We strongly work with Greek government, the Ministry of Health, and the Public Insurance. We participate on the radiosurgery board, and we have the LinkedIn channel with 8,500 followers called Stereotactic Radiosurgery. We are operating with two systems, one with isocentric in Thessaloniki and one non-isocentric in Athens. And we are working now in a program for skull-based meningiomas. We're analyzing our results, so I cannot show you anything, but I can show you just referred in 3 cases. We have a first case with a nice response after 3 years irradiated of a meningioma cavernous sinus. That's another case with meningioma skull-based in cavernous sinus, which is this is before the treatment radiosurgery. This is after the treatment radiosurgery, and you can see how it was enlarged in 6 months because of necrosis, and finally how in 12 months was shrinked. And finally, this is the last case. It's a case that with a middle deficit ocular model with a CPA meningioma, and that was treated in 2021 January. And as you can see, we have a response after 2 years. But in another level, we find out that we have a possible relapse. So we proceed in a second radiosurgery on the frontal part of cavernous sinus. And after 1.5 years, we have a stable local control with neurological improvement. Conclusion: radiosurgery is a safe and efficient therapy for skull-based meningioma. We have a high rate of tumor response and neurological improvement, low risk of complication. Molecular and genetic profile of the tumor is a challenge for better outcomes. Modern imaging is a precious tool, and selection of proper dose is crucial. Thank you.
Thank you very much. And I want to thank my co-chair for all the energy you're running around with. There is just time for one question, if anyone would like to ask.
No question.
Yep.
Go on.
For both presentations, all this data are find their way in some database, or how do you handle all the data that you have, all the experience?
Can you repeat the question?
Yeah, if all the data that you have shown, you and also the previous speaker, if they end up in a database.
I don't think that in radiosurgery in Greece there are so much experience. We working now in programs because we think that this should be organized. We have a program the last 5 years in Greece for CNS tumors. Now we remove also an SBRT startup radiotherapy for lung cancer tumors. So we're trying to put all this data inside with programs. Now we do a program for Meningiom, we have a program for acoustic neurinoma, and we start with a program for brain metastasis. It's very difficult because we are not a national society. We are a private society with people that are very interesting on radiosurgery. We are focused there. We don't care about radiotherapy in the rest parts. It's a joke telling that, but that's what we're doing. We like radiosurgery and we're doing only that. So
yeah, national registry.
Does not exist.
It's not existing. I mean, I don't know. I mean, it's
Okay. Thank you very much. We can continue with at the very end.
Just one more minute, please.
Yeah, here closes the session in this room, but I just wanted to remind you that in the main auditorium, Professor Roberto Orecchia and Arnold Campos are giving a presentation in the framework of the Aristotle Medical Forum in the session of the role of artificial intelligence in radiation therapy. So I encourage you to just step in the main auditorium. Thank you very much.